Good morning, everyone. Dr. Randall Gates, board-certified chiropractic neurologist, also a chiropractic physician at Gates Brain Health. Today, I'm talking about perilymphatic fistulas. Recently, I've been discussing a number of conditions that cause vertigo and dizziness, and I'm going into some of the more esoteric conditions or less common conditions, so to speak. Perilymphatic fistula is one of them. I think it's good that we discuss this because fistulas have overlapping symptoms with other vestibular disorders. So hopefully this is of some information to you, and it may be of some information to loved ones who may have the rare circumstance of developing a fistula. So without further ado, I'm actually going to bring in this slide from the Meniere's talk, so you can ignore the histology, pathophysiology slide and all this writing over here. I like this diagram because it's a good representation of the inner ear. Here you can see the cochlea, which looks like a conch shell. You see here these three looping canals of the vestibular system, and then some other structures here like the utricle and the saccule right in here. So that's your inner ear anatomy in a few seconds. What's important to know for fistulas is that, and good morning to everyone who's joining, with fistulas, you have basically leakage at two spots. Right here is called the oval window, and the oval window is where your middle ear really connects to your inner ear for hearing. So you have this bone called the stapes. It kind of looks like a stirrup that you would put your foot in if you were riding a horse. So the stapes connects to the oval window. So when you have sounds coming into your inner ear, they first go into your external portion of your ear. They then get transmitted to your tympanic membrane, which is like a drum, so they call it your eardrum. As the eardrum vibrates, it sends signals through two other bones called your malleus and your incus, and then it goes to the stapes, and the stapes pushes on the oval window, which then sends certain frequencies of vibration down through basically your cochlea, and that is how your hearing mechanism works. There's more details to it than that, but that's the generality from the fistula standpoint. Now, this fluid also ultimately is released, or excuse me, the pressure is kind of dissipated through this thing called the round window over here. So the pressure from the oval window, just think if you have some sort of like membrane that you can push in, the fluid is going to have to go out, and there's going to have to be some relief of that pressure, so to speak, not per se drainage, but pressure release at the round window. Now, with fistulas, in essence, what we have is leakage of perilymph from either the round window or the oval window. Within your inner ear, you have something called endolymph and you have perilymph. Endolymph is on the inside, perilymph is on the outer portion, but basically there's a parallel membrane that separates these two compared to your temporal bone of your inner ear. Just think of like a peanut butter and jelly sandwich, so to speak. And so the perilymph can start to drain from the round window or the oval window in certain situations. Namely, when people are studying perilymphatic fistulas, they say there are a variety of causes. So you can have barotrauma. So like you go scuba diving and there's so much pressure in your ear and you don't come up correctly, that can create a perilymphatic fistula. Also, if you're sneezing really hard or straining really hard, that can be a force that creates enough pressure to cause a perilymphatic fistula. Other things, which are actually more common than we would think, and interesting, it seems to be higher in incidence in certain societies where they use Q-tips more than others, is this accidental trauma of someone having a Q-tip in their ear. Maybe they're walking around, they hit the Q-tip, or they hit their arm, which then jabs their inner ear, and that can actually create a perilymphatic fistula. There's also some reference to idiopathic perilymphatic fistulas, and I'll get to that because now the current thinking is that those are another pathology, not perilymphatic fistulas. Nonetheless, when we have either barotrauma, some type of forced Valsalva maneuver, sneezing, Q-tip accident, what happens is there's a pressure damage to the inner ear, and it will create sudden onset hearing loss, tinnitus, and or symptoms of dizziness most commonly, or you may have vertigo. And so the key differentiator, if you look at those symptoms, okay, let's say hearing loss, ringing in the ear, dizziness, and or vertigo, those very much overlap, particularly with Meniere's disease. And I talked about Meniere's a lot, I think, last week. And so with Meniere's, there are a variety of different presentations. It's not always just vertigo, hearing loss, and ringing in the ear. Sometimes people just have vertigo. Sometimes they have vertigo and ringing. Sometimes they more have sound sensitivity and ringing and just nebulous dizziness. It all depends on where the swelling in the inner ear is manifesting damage. But the differentiator here is that with perilymphatic fistula, there typically is some sort of trauma. So if you know someone and they're saying, you know, I think I have Meniere's disease, but you say, okay, when did it start? And they said, well, yeah, it started after I jabbed my ear with a Q-tip. You want to start thinking fistula. Or I was doing a heavy lifting session, or I was sneezing really hard because I had this viral infection. You want to think fistula. For the idiopathic cases, what we're now seeing, if you look at this diagram of the inner ear, you see these looping canals. The superior semicircular canal can have an erosion of the temporal bone at its most apical point. You could think of it that way. And in that sequence, basically, people can develop something called superior semicircular canal dehiscence, where the temporal bone erodes for that superior semicircular canal. It can actually happen for the posterior canal. And the current research on fistulas is such that they think that the idiopathic cases of fistulas are not actually fistulas. They call them third window syndromes, where there's erosion in these areas of the semicircular canals. So let's hide this diagram. Let's go stream. So just again, recapping symptoms, they're often audiological and vestibular. They may be very similar to other vestibular disorders. The key differentiating factor, again, is typically some type of barotrauma or physical trauma. Common symptoms are tinnitus, vertigo, or dizziness, hearing loss, instability, feelings of ear fullness, nausea and vomiting. Okay, we'll hide that. Show on stream. Imaging is becoming more and more important. We can use certain types of CT and MRI to see basically signs of air in the inner ear, referred to as the pneumolabyrinth. So if you have damage to this round window or oval window, you can then have air that comes into the inner ear. And as a consequence, you can see that on imaging, and it's diagnostic. They can also perhaps see fluid in the round or oval windows, and particularly they see that with ENT examinations, where they use really sophisticated equipment to get in there and look at that. Okay, so then in terms of treatment, ensuring that it's a correct diagnosis is really important. Basically, it depends on whether there's a known cause or an unknown cause. The blood patch procedure is a common one. Also, there are other types of grafting procedures where they may take fascia from your temporalis muscle or from your tragus right here, and they basically try to sew in that connective tissue to the oval or round window. The perilymphatic fistula awareness is important because there can be a surgical fix to this, whereas like with Meniere's disease, there's not an immediate surgical fix. Usually a surgical procedure is done way later in the diagnosis, way later in the disease course, so to speak, after people have tried everything. But with fistulas, you can do a surgery which can help a person's symptoms right away. Conservative management is also an option where, in essence, the person kind of just lays in bed and tries not to strain doing anything. But fistulas can be really disabling. People can have vertigo that lasts a really long time, or hearing loss, or severe ringing that just goes on and on and on. So surgical approaches are typically what are opted for so someone can get out of it as soon as possible. But, you know, the activity restriction is an option. And I think that is pretty much it. So we'll show this in stream. So this is a quick video, but just want to give you some awareness of perilymphatic fistulas. Again, they overlap in symptomatology with other inner ear diagnoses. There is something called the fistula test, which is where someone applies pressure to their tragus and you can move pressure in and out. And if that creates some symptoms, it might be a fistula, but that can produce a false positive in Meniere's disease as well and some other inner ear syndromes. So hopefully this helps, and I'll be back soon with another broadcast on something inner ear related, most likely, or eye related, and send me any questions. All right, everyone, have a good Thursday.